Welcome back. After coffee, now we have Mr. Bhaskar Ram, one of the ENT consultant from Aberdeen Royal Infirmary. He has got an extensive experience in skull-based surgery, rhinology, as well as otology. He's a great teacher. He runs many courses, and he's going to give you talk about um, Rhinology. He is available, but we have he kindly recorded his talk, and that voice technical difficulties.
A very good morning to all of you, ladies and gentlemen. My name is Mr. Bhaskar Ram, ENT consultant, working at Aberdeen Royal Infirmary. A very warm welcome to all the delegates for participating in this Scottish Radiology Conference. I really hope that you find this conference useful and hope that you would learn some tips that you can put this into your day-to-day practice. I live in Aberdeen, which is in Scotland. It has some beautiful golf courses. It is rich in oil, and we are very fortunate to have the famous Balmoral Castle, where the Queen Mother and the royal family visit every year. Scotland is a very beautiful place. It has some lovely beaches, beautiful mountains, serene lakes where you can spend your summer. And I would like to warmly welcome all the delegates to come to Scotland during summer, hopefully when the COVID situation settles. I would like to disclose that I have taken some images from Radiology Assistants and from Google, mainly for teaching purposes only. Over the next 30 minutes, I will go through the following topics. One, look at the common radiological modalities that we use in rhinology, and then look at the role of imaging for surgical mapping and surgical planning. We'll then go through some differential diagnosis for unilateral sinus opacification, and then look at the imaging modalities that we currently use for CSF leaks, and conclude with imaging for nasal tumors. The most common modality that we use is the CT scan of the paranasal sinuses in the management of chronic rhinosinusitis. When we come across any complications of sinusitis, we certainly would recommend an MRI scan. CT angiogram is used mainly for skull-based surgery, such as pituitary surgery and other endoscopic sinus surgery. Angiogram is again reserved exclusively for vascular lesions to identify the source of the blood supply to the tumor, and also for preoperative embolization, such as a case of angiofibroma. PET-CT is used, just like in head and neck tumors, mainly for post-tumor treatment surveillance. When we request an MRI scan, we are given three sequences. One, a T1, a T1 GAD, and a T2 sequence. How do we differentiate between these three, and what information can we get or can we obtain from these sequences is the next question. As a layman, I use this table for me to differentiate between a T1 and a T2. In a T1, the CSF is black, the fat is white, gray matter is gray, and white matter is white. On the other hand, in a T2, CSF is white, fat is darkish, the white matter is gray or dark, and the gray matter is white. This I find quite useful when I want to check whether it's a T1 or a T2. Now, when we come to the sinuses, we may have a lesion which can fill the nasal cavity and can also obstruct the sinuses. This will lead to retention of secretions, which can be of fluid nature or very proteinaceous, thick, inspissated nature. So how do we differentiate on a scan between these three parts? In a T1, the mass will appear darkish. The thick proteinaceous secretions, the inspissated secretions will be very bright. On the other hand, if you look at a T2, the fluid, if the sinus is blocked with just fluid, which is not very proteinaceous, it will appear very bright, similar to the CSF fluid. Now, if the lesion is a solid mass, how do we differentiate a benign lesion and a tumor? This is where a T1 GAT comes into the picture. If the lesion is benign, it will show peripheral enhancement of the lesion. On the other hand, if it is a tumor which has increased circulation or increased vascularity, the whole lesion brights up. So this is a simple way that I use to distinguish between tumor, benign lesion, secretions, and the fluid retention. Now I'll go through some simple case presentations. Here is a 37-year-old man who presents with bilateral nasal obstruction. Nasal endoscopy shows polyps on both middle meatus. So this is a very common scenario we see in our outpatient clinics. We would treat them medically with steroid tablets, sprays, and NASEUs. And if they don't improve, if they don't benefit from the medical treatment, we will recommend surgical intervention. So we would request a CT scan of the sinuses before operating on these patients. Here is a coronal view of the CT scan showing mucoperiosteal thickening of the right and the left frontal sinus. One can also see opacification of the right ethmoidal sinus and the left ethmoidal sinus. One can see a very prominent ethmoidal artery on both sides in this particular slide. Here we can see opacification, we can see the sphenoid sinus. The septum appears to be in the midline. There is mucoperiosteal thickening along the floor of both the sphenoid sinuses. Now, when we decide to list this patient for surgery, and before putting the instruments in the patient, I would strongly recommend that we go through these scans in the multi-planar or a coplanar view to get as much information as possible of the important structures within and around the sinuses before surgery. Now, for the benefit of juniors, I'm going to go through some very basic radiological anatomy very quickly. Here is a coronal view of a CT scan. It shows well-pneumatized sinuses. I would like you to concentrate on two structures in this slide. One is your uncinate process and the maxillary sinus. The maxillary sinus goes towards the infundibulum, then becomes the hiatus semilunaris and drains into the middle meatus. Here we can see a cell here. This is the infraorbital cell or the Heller cell, which is quite prominent on the left side. In this slide, let us focus on the roof of the orbit. As we come medially, we come to the fovea ethmoidalis, which is a thick bone here, which leads on to the lateral lamella of the cribriform plate. This is the crista galli. This is the lamina fibrosa. And we can see the depth of the cribriform plate. We can also see a small protrusion here. That is your ethmoidal artery going along the skull base. In this slide, we can see there is a good pneumatization above the orbit, the supraorbital cells. And when we see such pneumatization, we can see the ethmoidal artery coursing through that. So here it is loose. It is not close to the skull base. It is at a high risk of injury during endoscopic sinus surgery. So the dry home message in this slide is, when you see a supraorbital cell, be careful and look carefully for the ethmoidal artery. Now let us focus our attention to the cribriform plate and the depth of the cribriform plate. Here it is small, about 3 millimeters. Here it is much deeper, and here it is much, much deeper of more than 7 millimeters. So this is very important when we perform endoscopic sinus surgery. The deeper the cribriform plate, there is a higher risk of damage to the skull base when we perform endoscopic sinus surgery. In addition to the depth, also look for the symmetry or asymmetry of the fovea ethmoidalis and the cribriform plate. Here it is asymmetrical. Here you can see the right side is much deeper compared to the left. In such situations, again, be extremely careful when you're performing endoscopic sinus surgery because the risk of skull base penetration is much higher on the right side compared to the left. Now let us focus on to the orbit and the medial orbital wall. On the right side, the coronal CT scan shows a normal lamina papresia. On the left side, we can see the lamina papresia is pushed medially. There is fat protrusion into the ethmoidal sinus. Again, this is a high-risk situation. When we put the instrumentations, we can very easily get into the orbit, into the fat, and even catch the medial rectus. And this can lead to severe diplopia and devastating complication for the patient. Now let us focus our attention to the sphenoid sinus. Here we can see a sphenoid sinus which is well pneumatized. We can see a septum almost in the midline. On the right side, we can see the septations going laterally, and watch out for these because they can get attached to the internal carotid artery. On the left side, the pneumatization is the septation is incomplete. In this slide, one can see a well pneumatized sphenoid sinus. There is a horizontal septation. So when we come across horizontal septation, think of an Onodi cell. An optic nerve can be very close to it or through it. So there is a higher risk of damage when you see a posterior ethmoidal cell or the Onodi cell. In this slide, we can see the Onodi cell. We can see there is pneumatization of the clinoid process and there is optic nerve running through it. Again, when we perform the surgery, there is a higher risk of damage to the optic nerve in these situations. Equally, we know that the lateral wall of the sphenoid contains a very important structure, your carotid artery. It can be dehiscent and watch out for this dehiscence. Again, very crucial point to look for when we perform any endoscopic sphenoid surgery or pituitary surgery. Now, moving on to the frontal sinus, I find the sagittal view to be extremely useful. It gives me all the information that I need to do when I'm performing a draft-free procedure. Now, in this sagittal view, we can see the anterior table, the posterior table, and the frontal sinus. It leads on to the frontal ostium, and below the frontal ostium, we had a frontal recess and the drainage pathway. Anteriorly, it is bounded by an acarnaceous cell, posteriorly by the bulla, and sometimes the suprabullar cell. Now, this pneumatization around the frontal recess can vary. Anteriorly, you can have more than one cell, such as here, or you can have a cell that is extending into the floor of the frontal sinus, or you can have an isolated cell within the frontal sinus. These cells are called as the Kuhn cells. So in this section, I would like to conclude with this message and ask you to remember this mnemonic, close or closet. So whenever you're planning for any endoscopic sinus surgery, go through the scans using this mnemonic. C stands for cribriform plate. Look for the depth and look for the asymmetry and look for any erosions. Check the lamina papresia, check for any dehiscence or medial orbital fat prolapse. Check for horizontal septations within the sphenoid, check for the Onodi cell and the optic nerve. And when you look at the sphenoid, look at the pneumatization of the sphenoid, look for the carotid artery, look for any dehiscence of the carotid artery, and look at the insertion of the septations within the sphenoid sinus. When you're looking at the ethmoidal artery, see whether it is close to the skull base, see if there is a supraorbital cell, see if it is isolated and sitting on a pedicle. And when you're dealing with maxillary sinus, always check the floor of the maxilla and see if there is any periapical infection, which could be the source of the infection. Now we go to the next section, which is unilateral sinus opacification. And let us go through some case scenarios for this. Here is a patient who presents with left-sided nasal obstruction. A nasal endoscopy shows a polypoidal or a polyp-like lesion arising from the left middle meatus and extending posteriorly. CT scan coronal view shows a homogeneous lesion filling the nasal cavity. It is not expansile, it is not erosive, it is unilateral, and there is some mucoperiosteal thickening of the left maxillary sinus. On a T1 sequence with contrast, one can see a lesion, and there is peripheral enhancement. There is some dark signal within it. This tells me that this is a benign lesion. And on the axial view, you can see the same, a smooth contour lesion extending into the postnasal space, again confirming that it is a benign lesion. Putting all these together, we know that this is a simple case of an anterochoanal polyp. Now, here is another patient who presents with recurrent left-sided sinusitis, nasal obstruction, purulent nasal discharge, and pain radiating to the teeth. Here we can see nasal endoscopy shows some pus in the middle meatus. And when we do the CT scan, we see that there is opacification of the left maxillary sinus. It is homogeneous. There is no calcification within it. There is no erosion. But look more closely, and one can see a periapical lesion. So this again tells us that the source of the left maxillary sinusitis is from the teeth or from dentition, and the patient will need a combined treatment with the dentist and also an endoscopic sinus surgery, stroke, middle meatal antrostomy. Now let us look at this scenario. Here is a patient who presents with left-sided toothache and facial pain, and one can see a unilateral, uniloculated, bony cystic swelling, and it contains within it an unerupted crown of a teeth, and the most likely diagnosis here is a dentigerous cyst, and you would refer this patient to the maxillofacial surgeons for further management. Now, here is another patient who presents with double vision, and when we examine him, we see that the right eye is slightly more sunken. There is some lid retraction. There is an ophthalmos, and when we concentrate on the coronal view of the CT scan, we see that the right maxillary sinus is more hypoplastic than the left. It is atelectatic, and there is indrawing of the lateral wall and the inferior orbital wall. Medially, we can see the uncinate process is very atelectatic. It is very indrawn. It's almost touching the orbital wall. So this patient will need a combined endoscopic sinus surgery and reconstruction of the orbit, working closely with the oculoplastic surgeon. When we contemplate on uncinectomy, we have to be extremely careful. Otherwise, we will damage and get into the orbit, and the middle meatal antrostomy done in a very careful way. Here is another patient who presents with a right-sided nasal obstruction. One can see a papillomatous lesion. Clinically, we think it's inverted papilloma. We would get a CT scan first, and it shows a lesion in the right nasal cavity and extending into the maxillary sinus. It is homogeneous, and this is the bony window, and there is widening of the maxillary ostium. And the soft tissue window shows the lesion to contain variable hyperintensity, again suggesting that this is likely to be a tumor. And when we do an MRI scan, this is a T2 sequence. As we can see the CSF fluid nicely lighting up, and we see a mass in the nasal cavity extending into the maxillary sinus. And it is of variable signal intensity, similar to that of the brain, and it is called as the convoluted cerebriform pattern, which is very typical of inverted papilloma. Now, we want to know how much of this is in tumor and how much of this is fluid and inspissated secretions. Here we can see a very bright, high signal intensity in a T2, and that should be the fluid which is retained in the maxillary sinus. Laterally, we see a low signal intensity lesion, and this could represent the thick inspissated secretions trapped in the maxillary sinus. And when we look closely, as we go into the ethmoidal sinus, we see a signal intensity similar to that of the brain, and this could represent a mucosal thickening, or it could represent part of the inverted papilloma. So how do we differentiate between these two? When we do a T1 contrast sequence, we can see that the whole tumor is lighting up, and the fluid is dark in T1, and that confirms that that is fluid. But this here, it does not take up the gadolinium. So this has to be a simple mucosal thickening or mucosal edema in the ethmoidal sinus. So why do we need this information? This helps us to decide on the surgical planning. Whether we need to do endoscopic Denkers or endoscopic medial maxillectomy? Do I need to go well into the posterior ethmoidal cells? So this is how these scans helps us in surgical planning. Now let us go to the next scenario. Here is a 34-year-old patient with a 2-year history of right nasal obstruction and nasal discharge. This is a coronal CT. We can see the lesion involving the right nasal cavity and the maxillary sinus and the frontal sinus. It is of variable intensity. There is high attenuation signal within the maxillary sinus and the ethmoidal sinus. This is typically seen in patients with fungal sinusitis, most likely an allergic fungal sinusitis, because we don't see any other bony erosions or bony destructive lesions in the sinus walls. When we go in during surgery, we find that the secretions within the sinuses are very thick, very tenacious, almost like a peanut butter in appearance, and this is classical picture of allergic fungal sinusitis. Here is another patient, 87-year-old farmer with a 3-year history of unilateral nasal obstruction, nasal discharge. The axial CT scan shows a lesion in the left maxillary sinus. It is not homogeneous. There are some central calcifications within it. The lesion is extending into the nasal cavity and also onto the contralateral side. The bony window again shows the same with some calcification within it. And when we do a T2, we see that this maxillary sinus showing evidence of pseudo-pneumatization. However, on a T1, we see that it is not pneumatized. It is actually a soft tissue mass. And when we put the GAD in this patient, we see that there's only peripheral thickening. So this is a benign lesion, and it is a solid mass, and it has low signal intensity on a T2. So when we combine these three, we conclude that this has to be a benign lesion, probably fungus in origin, and it turns out to, without any surprise, that it is an aspergilloma, and that's what we see when we do the midmetal antrostomy. So this is how imaging can be extremely useful in helping you with your diagnosis. Now we'll go to the next section on CSF leak. Here is a patient with a right-sided unilateral nasal discharge. So the key questions are, is this fluid CSF? 2, where is the defect? And is there any herniation of the ring contents through the defects? So these are the 3 main questions we ask ourselves. To confirm our diagnosis, we would all do a beta-2 transferrin test, and we would recommend the high-resolution CT scan of the paranasal sinuses to look for any defects, skull-based defects. Then if we find any soft tissue through the defect, then we will certainly get a T2-weighted MRI to look for any herniation, such as a meningocele or a meningoencephalocele. If the first, that is the sinus, if the CT and MRI are not conclusive, then we can inject intrathecally fluorescein dye to identify the site of the leak and complete it with a nasal endoscopic examination. Now, even if this fails and the patient continues to have a leak, then you may have to resort to a cystonogram. An MRT2 weighted cystonogram probably will give much better information than a CT cystonogram. Now, in this coronal view, we can see there is a herniation of some contents or soft tissue opacification around it. There is widening of the lamina cuprosa, cribriform fossa. So this is a classical site of the skull-based defect, and we can see we would probably push for an MRI to make sure that this is just a meningocele and not a meningoencephalocele. Here in this slide, we can see a patient who has a skull-based defect. There are some air bubbles around it. This is a postoperative patient who had rhinorrhea soon after surgery, and there is a suspicion that there can be a skull-based penetration at this point. And this can happen in endoscopic sinus surgery in difficult situations. And this patient needs to go to theater and repair of the CSF leak. Here is a T2 weighted image, coronal view. It shows CSF bathing the olfactory bulb, but we can also see the leak coming here and going into the nasal cavity, suggesting the site of the leak. Here is another patient who presents with a spontaneous CSF rhinorrhea, and the MRI scan in the sagittal view can see the CSF fluid completely bathing the pituitary, almost like an empty cellar. Then in this here, we can see the CSF fluid bathing the optic nerve very nicely. There are some features to suggest papillary edema, and the ventricles are slit-like. And when we do an MRI scan of the sinuses, we can see the right sphenoid is opacified, and it has a high signal intensity. And also there seems to be the herniation of the temporal lobe of the brain into the sphenoid sinus. So this can occur in benign intracranial hypertension. So when you see a patient with BIH with sphenoid opacification and it is more fluid, please make sure that you get an MRI scan as well, because the entire temporal lobe can significantly herniate through these defects, lateral defects, into the sphenoid sinus. Moving on to the last section, which is on tumors. As we all know, tumors can be benign or malignant. Here is a patient with a left-sided headache, discomfort, and nasal congestion. We can see a bony lesion filling the left frontal sinus and extending quite significantly laterally as well. So from the ENT point of view, from the surgeon's point of view, if this patient is symptomatic, as we can see, it requires surgical removal of the osteoma. Now, a draft 3 can be extremely difficult to get the lateral part of the osteoma. So one would either use a supraorbital approach or an osteoplastic coronal approach to remove this lesion. Here is a patient who presents with diplopia, and one can see a lesion in the left frontal sinus. It is an expansile lesion, and we can see the posterior margin of the posterior table. And there are some areas suspicious dehiscence here. And when we do an MRI scan, we can see a high signal intensity lesion involving the left frontal sinus, and the globe is pushed down and out. It is smooth in contour. And this again confirms that this is a benign lesion and it is a mucocele. Moving on, here is an 18-year-old patient with recurrent epistaxis on the right side. One can see a lesion, and it appears to be rich in blood supply. It appears vascular. And when we do a CT scan, we can see a lesion in the axial view, filling the nasal cavity, extending posteriorly. And there is also widening of the pterygopalatine fossa. The mass also seems to extend and involve the sphenoid sinus and also the into the postnasal space. When we do an MRI T1 sequence, we can see that this is a high signal intensity lesion involving the nasal cavity, extending into the pterygopalatine fossa. There are some high flow voids within it, suggesting that this is a vascular lesion. Now, if you want to identify the blood vessel supply to this lesion, one would do an angiogram. This again helps in surgical planning and also for pre-operative embolization. Here is a 55-year-old patient who presented with a right-sided nasal obstruction and right-sided facial pain. One can see a lesion in the right nasal cavity. The lesion is extending into the pterygopalatine fossa. The pterygopalatine fossa is widened. There seems to be some mild erosion of the pterygoid plates. The lesion confirmed it to be an adenoid cystic carcinoma, and patient underwent endoscopic transpterygoid approach to remove this lesion, and she is also getting postoperative radiotherapy. Again, the MRI scan confirms the lesion and extending into the pterygopalatine fossa. So this lesion usually involves the maxillary division of the trigeminal nerve, and it can extend intracranially as well. Here is a 64-year-old smoker who presents with right-sided nasal obstruction. Mass is seen in the nasal cavity on endoscopy. MRI scan shows a solid mass filling the right nasal cavity. This is a T2 sequence. We can see thick fluid secretions filling the maxillary sinus and the ethmoidal sinus. Here on the deeper cut, we can see the lesion extending up to the skull base. The fat plane is well preserved, so it has not breached the cribriform or the skull base. And here we can see that it is not involving the olfactory bulbs. And in this axial view, we can see the lesion extends into the right sphenoid sinus, and there is some unilateral mastoid opacification as well. So the advantage and the use of MRI scan is to identify the site of the tumor, the extent of the tumor, and to see whether it is extending intracranially, laterally into the orbit, or medially into the contralateral nasal cavity. And also we should do the CT or MRI scan of the neck to check for any neck metastasis. I find this staging picture very useful. For me, it tells me that we need to assess the tumor, whether it is extending anteriorly through the bone, subcutaneous tissue, or the cheek, skin of the cheek, or if it extends posteriorly into the pterygopalatine fossa and infratemporal fossa, or where it extends medially into the postnasal space and the clivus, and laterally into the orbit or to the orbital apex, or into the or superiorly into the cribriform plate and into the brain, and medially into the contralateral side, or inferiorly into the heart palate. So if we use this sort of a algorithm, it will be very useful for radiological staging in sinonasal cancers. Here is another patient who presented with a left-sided nasal obstruction. This is a coronal CT. We can see a lesion involving the nasal cavity, and there is some erosion of the cribriform plate. There's a mass which is extending, and there is some erosion of the septum as well. On the axial view, we can see the lesion extending to the contralateral side, and it is filling the epimodal sinus. There are some areas of erosion of the medial maxillary wall. MRI scan, we can see the solid tumor mass which is filling the left nasal cavity, going on to the opposite side. It is also breaching the fat plane here, and it's extending into the brain. So this raises a strong suspicion that it is likely to be an olfactory neuroblastoma with retained secretions here, and there is some mucoid retention of the fluid in the sphenoid sinus as well. So this is a classical case of an olfactory neuroblastoma. This is the last slide. Here is a patient who presented with a nasal obstruction. One can see on the CT a large lesion, destructive lesion with calcification within it. So this is a classical case of a chondrosarcoma of the nose. So I'd like to conclude my presentation with the following points. Firstly, know your anatomy. Know the basis of the scans of what T1, T2, T1 GAD actually gives. Try to read the scans as much as you can yourself, and then check the report. And listen to some wonderful lectures in the internet. I find the AOT ENT lectures, ERS, European Rhinology Society lectures very useful. And we also in our department have bi-weekly radiology meetings, and we have great cases which we discuss. And it's a wonderful learning session, and I really enjoy working with my radiology colleagues. And I gain a lot of knowledge from them. I would like to thank all of you for listening, and I hope that you find this session helpful. Thank you.
Absolutely great. Thank you very much, Mr. Ram. That's a great lectures with loads of clinical information and slides. So there are questions, 5 questions. Can you see in the Q&A, or do you want to read?
Yeah, I think the first question is the lesion showing calcification in CT, fungal, inverted papilloma. So I think I've covered that in the lecture. The most common finding that I find is calcification is usually in a fungal sinusitis. Inverted papilloma, you can see variable attenuation signals. Again, that is the other reason. That is the other condition that you may have to rule out in a CT scan, and maybe perform even an MRI scan to differentiate. And I've shown you on the slides how to differentiate a fungal etiology and inverted papilloma using your T1 GADs. So we can use the imaging to our advantage to differentiate these conditions as well. regarding bony erosion in what benign paranasal sinus lesions. So usually the most common bony lesion that we come across, benign bony lesions, is the mucoceles. They are usually expansile, they are not infiltrative, they are not erosive. So that is one thing you have to be careful. And also, I would like to stress one other point. If you see a patient where MRI scan is very abnormal, but when you see a CT scan, it's ground glass. So don't be surprised with the MRI scan. Don't get caught out. It can be a simple fibrous dysplasia as well. So you got to take that into account when you're managing patients with fibrous dysplasia. Regarding the next question on corneal stenosis, I think we're going to have a wonderful lecture in the afternoon. So we will be covering that in the afternoon session on corneal stenosis and piriform aperture stenosis. It's a very good question. We will certainly do that. Regarding the next question, in meningoencephalocele, imaging can help to differentiate between a functioning. I doubt very much. We have the neurosurgeons also in this panel. They might highlight it, or they might enlighten us later. But in most cases of CSF leaks that we come across, the meningocele and the minimal encephalocele that we come across, they are not functioning, the gliomas. So they are non-functioning tissues in patients that we see in the CSF leaks with herniations. Okay, unless of course it is a large defect where there is a temporal bone herniation, temporal brain herniation, then you will get active brain in that. But in most of the small leaks that we come across, that tissue that we see in the CSF leaks are non-functioning brain tissue or non-functioning meninges. Yeah. Olfactory dimensions in the context of evaluation of anosmia, I am not sure about that. I haven't done the literature search on that. All I can say, for me, olfactory fossa dimensions is very useful when I'm performing my endoscopic sinus surgery. I hope I've covered almost all the questions. Thank you.
That's right. Thank you. I think, Ram, would you mind introduce the next speaker as well?
Yeah. Okay. So our next speaker is Mr. Anastasios Giamouridias. He's an excellent neurosurgeon who has recently joined our team at Aberdeen Royal Infirmary. He completed his surgical training in London. He worked at St. George's, King's, and St. Thomas's. He completed and he underwent skull-based training at St. Thomas's. He then went on to go on to States and did a fellowship in minimal endoscopic skull-based surgery at Weill Cornell. And we are very delighted to have him here today. And he's going to now talk to us on the imaging in anterior skull base. Over to you, Anastasios. Thank you.
Thank you. Can you hear me?
We can see you. You're going to share your slides, yeah?
Yeah.
Yeah, we can see your slides, Anastasios. Thank you.
Fantastic. Thank you. Thank you for inviting me. So we're going to discuss regarding anterior skull base radiology. I have no disclosures. Skull base is a fascinating and quite complex area where all the vital neurovascular structures are either entering or exiting the brain. So a little bit about the anatomy of the anterior cranial fossa, starting from the front with the cribriform plate, going backwards in the medial plane on the planum sphenoidale, followed by the tuberculum sella, followed by the pituitary sella, and the dorsum sella and the clivus. Laterally, we have the orbital roofs and the sphenoid wings, but that goes more towards the middle fossa. So we're gonna focus on the anterior one. Axial and sagittal CT reconstruction 3D of, again, the anterior cranial fossa, just to familiarize you a little bit more with the anatomy on a sagittal plane. This is the endoscopic endonasal transsphenoidal anatomy. The very important landmarks are the optocarotid recesses in order to protect the most important structures in during that approach, which are the carotids and the optic nerves, obviously. This is a slide showing you where we will identify neoplastic tumor and specifically meningioma pathology in the anterior cranial fossa. So starting from anteriorly, again, it's the olfactory groove, the planum sphenoidale, as we said, the tuberculum sella, and then the orbital roofs laterally as far as the anterior fossa is concerned. So the pathology that we usually see in the anterior skull base, tumors-wise, thankfully, most of them they're benign, meningiomata or pituitary adenomata. Craniopharyngioma is a benign histologically tumor, but with quite malignant behavior because it's strictly adherent to the optic apparatus, the ACOM complex. So it's very difficult to completely remove it, as well as the hypothalamic structures, without causing significant morbidity. Therefore, we see several recurrences, and we have multimodality approaches to tackle them. Chordoma and nasal malignant disease that you are more familiar than me are the aggressive pathologies that we're dealing with, mainly in the anterior fossa. Cystic lesions-wise, dermoids, epidermoids, arachnoid suprasellar cyst, and Rathke's cleft cyst. We'll see a few examples. The Hiessen syndromes that we're dealing with, Mr. Ram mentioned nicely the meningocysts and the CSF leaks. I will give you my take about this in the end of the lecture. And the infections, just a quick look. Again, Mr. Ram covered this topic nicely with sinusitis. So pituitary adenoma, one of the most common pathologies that we're dealing with. Very important for us, it's sagittal and coronal T1 post-GAD reconstruction. So we can identify the optic chiasm, the optic apparatus, usually pushed superiorly from a large macroadenoma, and the invasion of the cavernous sinuses laterally. We're using the nose grading system for the cavernous sinus extension. Bottom left, I have an MRI T1 post-contrast showing you a microadenoma, so less than 1 centimeter, and a PET imaging, mainly useful nowadays when we have functioning pituitary adenomata, mainly acromegalic patients or patients with Cushing's, when you cannot really identify obvious tumor on the MRI scan. Therefore, we proceed with a PET in our unit with methionine PET. And we are one of the 2 units in the UK having PET scan in order to identify a target. Examples of pituitary macroadenomata, a giant one on the top, a standard macroadenoma on the bottom with substantial debulking. This is the setup in theater, how myself and Mr. Ram were approaching these lesions. Very extensive lesions can represent giant pituitary macroadenomata. That's an example of a patient who presented to our unit with hydrocephalus from this very, very extensive tumor. It was in the peak of the COVID as soon as it started last year. So we did very cautiously, safely and quick, endonasal biopsy for histopathology because the tumor was protruding within the nasal cavities. And probably you can identify there are 2 shunts placed in order to treat the hydrocephalus from the artifact on the axial MRI. On purpose, I have the T1 sagittal up here in order to demonstrate to you that bright signal. It's hemorrhagic components of the tumor, and this is what you can see on the T1 without contrast. Pituitary apoplexy, that's a medical emergency. Patients present quite unwell with Addisonian crisis, hyponatremia, hypotension, complete pituitary dysfunction, and most of the time significant ophthalmoplegia or visual loss. The MRI scan will show you again hemorrhages, which looks like a bright signal in T1, and this is how it's going to look also on your plain CT hyperdense. Next pathology in the sella region, it's a craniopharyngioma. The main differential diagnosis that it can be done even on a simple lateral skull X-ray is that the pituitary adenoma will, I'll go back, will enlarge significantly if you see the sagittal reconstructions, the sella. A craniopharyngioma will not enlarge the sella, but what it will do, it will erode the posterior clinoids. So that's a good radiological sign for your differential diagnosis. And mainly there are multicystic lesions with also calcifications. Next pathology, it's the clival chordoma, which is an aggressive tumor which needs maximum safety bulking. Most of the times we're able to achieve this through the entonasal endoscopic route. Patients usually present with a sixth nerve palsy. It's important to differentiate it with versus a chordosis fistulifora, which is an absolutely benign condition. Most of the times it's an incidental radiological finding. And there are some specific characteristics to differentiate it. As you can see, the chordoma, it's a quite aggressive radiologically looking lesion, expansile, lytic. The echordosis fistulifora, it's usually has very smooth margins. We do provide close radiological surveillance for the ones that we believe they are echordosis fistulifora for a few, at least 2-3 years. And when we confirm stability with CT and MRI, then we discharge the patients. We can say comfortably that it's not a chordoma. Nasal cancer with significant extension, intracranial, that's a recurrent case, which we performed a combined approach through a large bicoronal flap in order to tackle the intracranial component and simultaneous endoscopic debulking of the nasal tumor with anterior skull-based reconstruction from below and upwards. This is an olfactory groove meningioma. As far as meningioma is concerned, so as we said, we will start from the front. And you can see significant perilesional swelling. It causes anosmia and cognitive decline. And you can see the postoperative result with a dural expected enhancement, but no residual gross tumor. That's a suprasellar meningioma. It's difficult really to say if it is tuberculum sella or planum sphenoidale, but doesn't really make much of a difference. We can name them suprasellar meningiomata. They present usually in middle-aged females. They can cause rapid visual deterioration, as this patient suffered. We removed this recently through an eyebrow supraorbital mini craniotomy, complete resection. You can see on the top picture the left optic nerve with a 45-degree angled scope visualized from below and confirming no residual tumor. It's a grade 2, so it needs close radiological surveillance, despite that it has been completely debulked. That's an orbital roof meningioma, again anterior but more lateral. People name it sphenoid wing sometimes, but it's really an orbital roof one, which it's causing also orbital roof hyperostosis. Again, I prefer to remove this through an eyebrow approach and avoid big flaps. And you can see the postoperative result. This is the eyebrow approach that I'm using. It's a modification. We're using this even for extensive sphenoorbital meningiomata because the main aim here is to decompress the optic nerve. As you can see, it has been decompressed on the left side and provide histopathological diagnosis. Very large, very difficult, very extensive tumors, petroclival meningiomata, which mainly start from the anterior cranial fossa and occupy the whole skull base, causing significant brainstem compression, invading all the important vital neurovascular structures. As you can see, that has caused also hydrocephalus to the patient. So there is a sign, you can see the artifact from the programmable valve on the right parietal area. We're performing this with advanced intraoperative neuromonitoring using visual evoked potentials, monitoring 3, 4, and 6, and obviously the lower cranial nerves. difficult pathologies, it's much more preferable if you can avoid an operation or delay it as much as possible, as it does carry significant morbidity and even mortality, because all the little perforators are invaded. They're very frail and very easily can be damaged during the debulking approach. As far as cyst is concerned, as I said, suprasellar arachnoid cyst, completely same signal as the CSF. Rathke's cleft cyst, it might have a little rim enhancement, but you will not see significant enhancement. The main differential diagnosis here is a cystic pituitary adenoma. And very important to be aware of epidermoid dermoid cyst. The most important sequence that it will help you to differentiate from other cysts, it's the DWI, bottom left, which it will reveal the increased cellularity of this cyst. I'm saying it's important so you know prior to the operation what type of cyst you're removing, because epidermoids, again, they're strictly adherent to the important optic apparatus and the complex and the perforators. So they're not very easily completely removed all the time. Infection, just a little example, Mr. Ram covered this topic of frontal sinusitis causing the post-Puffy tumor, as we know, causing bony dehiscence in the frontal bone and intracranial extradural extension with a small extradural abscess to this patient, which we aspirate through with image navigation through the little dehiscence that already the infection has caused, followed by prolonged intravenous antibiotic therapy. And I brought the DWI again up to demonstrate that's post-operative, to demonstrate that you can see a little bit of fluid collection where we operated, but there is no restricted diffusion. So that means there is no residual infection. So your DWI, it's the most important sequence I find on infections and epidermoids, dermoids. And I will close with the spontaneous CSF rhinorrhea. So if it is a traumatic one, most of the times it will heal itself within a week. If it is an iatrogenic one, it needs to be repaired surgically. If it is a spontaneous, completely spontaneous nasal CSF leak, until proven otherwise, most of the times it's a result of increased intracranial pressure for some reason. Most of the times the phenotype, it's an obese patient with idiopathic intracranial hypertension or secondary to venous sinus thrombosis. Mr. Ram demonstrated very nicely on his MRI scans exactly the findings of an idiopathic intracranial hypertension, which is the tortuous optic nerves because of the venous stasis on the ophthalmic veins, the intracellular arachnoid herniation from the increased pressure, and the slit ventricles. So these are all pathognomonic of idiopathic intracranial hypertension. There is a lot of anxiety and excitement when somebody has clear fluid running out of the nose, confirmed with beta-2 transferrin. But very rarely these patients will develop meningitis because there is a valve mechanism. So very rarely, if you don't do anything, they will develop meningitis. Attempt to repair endoscopically and endonasally these defects, it's not very rewarding always because you have not really tackled the root of the problem, which is the increased pressure. And what actually you do is you disturb the valve mechanism. So you introduce meningitis, and meningitis is a very common result after attempts of repair for these patients. You need to address the root of the problem, and the most effective treatment is weight loss. So I refer these patients on to dietitians and general surgeons for bariatric surgery. Medical treatment involves acetazolamide, which can help sometimes. And if all that is refractory, then again, I'm not repairing because it doesn't work very well always and puts the patients in more risks. We proceed with CSF diversion procedure, which completely stops the CSF leak and avoids all the meningitis complications. Thank you, and please let me know if there are questions. I will stop sharing my screen.
That's very good. There's no questions. I'm glad that it is a very interesting talk, very advanced. That's brilliant. Thank you. Then thanks for taking the time, and no technical problems. I'll next speaker, Mr. Ram. Do you want to introduce Vamsi, please?
Yeah, Sangeeta, is she here or no? Okay, Mr. Vallam. Okay, so Mr. Vallamkondhu is a great colleague in our. Sangeeta, okay.
Yeah, I'm happy to introduce him if you want.
Yeah, sure, go ahead.
So Vamsi hasn't actually sent me an introduction, but we know him very well. He's been an excellent colleague. He started with us as a registrar and now has recently been appointed as a consultant, a very academic, very popular trainer. He has assisted us in organizing several national and international conferences. And I must mention, he's a gold medalist from the European ORL exam. And we really look upon him as a great colleague. So Vamsi is going to be talking on nasal and otological emergencies. Over to Vamsi. Thank you.
Great.
Thank you, Ms. Nini.
Yeah, so I managed to, he kindly agreed, I recorded his talk as well. So.
Hello, everyone. Good afternoon. I'm Mr. Vamsidhar Vallamkondhu, an ENT consultant at Aberdeen Royal Infirmary. I'm going to share a surgeon's perspective in imaging in nasal and otological emergencies. Why do we do imaging in emergencies? It could be to confirm the diagnosis, to define the accident, helps to plan treatment, including surgical approach, sometimes to monitor the response to a treatment. It could be a useful tool as an intraoperative stereotactic guidance. This is very helpful in complex patients or revision patients. There are various choices. CT scan remains imaging of choice in nasal and otological emergencies. Contrast enhancement can be used depending on the need. An MRI is useful in certain situations where CT may not be able to diagnose or may not be sensitive, especially like intracranial complications or cavernous sinus thrombosis. In such situations, MRI scan is a useful adjunct tool. These are some of the emergencies that I have come across at Aberdeen Hospital in nasal emergencies. Infectious cause remains the most common. As you all are aware, orbital complications form the most common cause for most common area in complications of sinusitis. The next comes the intracranial complications and then bony complications. I'm going to discuss a few of our case scenarios regarding the imaging of choices and management. The first case, a 3-year-old boy presented with 3-day history of flu-like symptoms, had periorbital swelling and left eye proptosis. It was difficult to examine the eye. Clinically, periorbital cellulitis was suspected. In these kind of scenarios, it always remains a question: to do a scan, not to do a scan. I've penned down few of the situations which should prompt us to do the imaging immediately, such as inability to assess the vision or eye symptoms of ophthalmoplegia, proptosis, bilateral edema, involvement of central nervous system, failure to improve even after 24 hours of IV antibiotics. We have carried out a CT scan in this child as we were not able to assess the vision. And this is a CT scan of the head axial image, which shows the striking feature is medial rectus lateralization and also medial rectus edema and collection around 3 centimeters into 5.5 millimeters. I have carried out an emergency procedure. The surgical approaches are external approach or endoscopic approach. Thankfully, I have managed to drain the subperiosteal collection endoscopically. The child remained very well, discharged home after 2 days. Next patient, 66-year-old lady who is known to have myelodysplastic syndrome, graft versus host disease. She is on high dose of immunosuppressive medication. She was an inpatient in our hematology ward, and she mentioned to the doctors that she noticed sudden onset of reduced vision and right eye was protruding out. Clinically, she was found to have second, third, and sixth cranial nerve palsies, orbital apex syndrome, or cavernous sinus thrombosis was suspected. Went on to have a CT head, which did show sphenoid sinus opacification. This is an axial image. On the right side, you would see opacified sphenoid sinus, and also this is the coronal image, which shows sphenoid sinus opacification. And in this axial image, there is a bony dehiscence in the posterolateral wall of the sphenoid sinus with some aeration. And in this coronal image, in the same area, that's bony dehiscence, which is superior orbital fissure and in continuity with optic nerve area. So there could be chance of fungal sinusitis. However, she went on to have MR venogram, mainly to rule out cavernous sinus thrombosis. As suspected, there was a good signal in the cavernous area on the left side and poor signal on the right side. But this asymmetrical signal, the suspicion was strong enough to suggest it was cavernous sinus thrombosis. She had sphenoidotomy done, mainly to obtain a tissue diagnosis and also to see if there is any sample to rule out fungal sinusitis. Intraoperatively, the sphenoid sinus did not show any overly suspicious features. There was minimal pus in the posterolateral part of the sphenoid area where there was the bony dehiscence, and that pus was sent for culture sensitivity. And sphenoid sinus mucosa was very edematous. That was sent for histopathology. She was treated as cavernous sinus thrombosis with anticoagulations and antibiotics. The next patient, a complication of frontal sinusitis. 16-year-old girl admitted to pediatric ward with right side significant frontal headache and a preceding upper respiratory tract infection. The CT scan was showing opacification of ethmoid sinuses and frontal sinuses. Clinically, this was regarded as acute frontal sinusitis, and she was started on medical management. Within a couple of days, she developed left-sided foot drop. Therefore, MRI scan was carried out. An MRI did show subdural empyema. The earlier CT scan wasn't sensitive enough to identify intracranial complications or that the child developed complications, and therefore MRI was able to pick up the subdural empyema. Either way, she needed the focus to be drained, focus of infection, and therefore ENT referral was made. This was in the preoperative planning. As you would see, the ethmoid sinuses, this is in the coronal image of the CT scan, the ethmoid sinuses were filled with most likely pus. And you could see anterior ethmoid canal, which is in line with the skull base, and this is reassuring, less likely to get damaged in the endoscopic sinus surgery. And this is a coronal image at the level of frontal sinus, a large frontal sinus with full opacification on the right side and smaller frontal sinus with some aeration on the left side. And this is the sagittal image at the level of frontal sinus, showing some agar cells near the frontal rhesus area. She was taken to theatre in view of external approach if needed, and endoscopic sinus surgery to drain these sinuses. However, in endoscopic approach itself, the sinuses were drained fully. I was able to see the frontal sinus after clearing the rhesus area, and therefore we did not need to carry out external approach. She was kept admitted for 4 weeks in view of long-term antibiotics and also monitoring of her subdural empyema. She had CTL imaging through MRI scan, which confirmed reduction of the empyema phase. As you would see, the coronal image of MRI scan, which shows empyema in this area around 6 millimeters, which was reduced to 2 millimeters in 4 weeks' time, and it was completely resolved after a couple of months. She remained asymptomatic since then. Another complication of frontal sinusitis, a 30-year-old patient admitted to District General Hospital with frontal swelling for 5 days. Prior to that, he had coryzal symptoms, and CT head was carried out there, which did show a complication of frontal sinusitis. Urgent referral was made to neurosurgery and ENT, and he was transferred to our hospital. These are CT scan images of the head with contrast, and the striking abnormality that you could see is rim-enhancing lesion in the frontal lobe and dehiscence in the posterior table of the frontal sinus and also in the anterior table of the frontal sinus in both sagittal and axial images. So this is a frontal sinusitis complication causing bony complication both to anterior table and posterior table. This patient was taken to theatre as a combined procedure. My colleague, Mr. Anastasios, neurosurgery colleague, has drained the extradural collection, and I have carried out frontal trephination, as it was extremely difficult to access the frontal sinus. As you would see, the frontal sinus drainage pathway is completely blocked, and therefore external trephination was carried out and pus was drained, and the drain was left, corrugated drain was left in situ for a couple of days until the drained minimal. This is immediate post-op picture, which did show aeration within the frontal sinus and the frontal trephination and the drain in situ with reassuring findings. However, he was under clinical surveillance radiologically, and in the follow-up MRI scan after 6 months, he developed a small mucocele within this frontal sinus. He's on our waiting list for that drainage of mucocele, possibly obliterating the frontal sinus. Next patient, sphenoid mucocele compressing the optic nerve reduced vision. This is a 65-year-old presented to ophthalmology with 3-month history of reducing vision in the left eye. Clinically, this was suspected as a compressive lesion in the optic nerve and progressive visual loss. MRI orbits were requested by them, and she was found to have sphenoid mucocele compressing the optic nerve. Therefore, ENT referral was made. This is the MRI scan, which shows a smooth, well-defined expansor lesion and the left sphenoid sinus almost compressing the optic nerve area on the left side. She was seen by my colleague, Mr. Ram. He's requested for an urgent CT scan, mainly to know the bony detail and also for surgical planning. This is the CT scan. It is an axial image and a coronal image. The axial scan does confirm an expansile lesion in the left sphenoid sinus, almost eroding the posterolateral wall. In the coronal image, it is clearly seen the right optic nerve with intact bony wall, whereas on the left optic nerve area, the bony wall is completely dehiscent, and you can define the expansile sphenoid mucocele. She was taken to theatre mainly to drain this sinuses and reduce the compression over the sphenoid over the optic nerve. This is mainly to obtain a diagnosis and also to reduce further damage to the optic nerve and vision. This is the post-op imaging after a week, which shows in the axial image clear ethmoid sinuses and the sphenoid sinus with good result. And this is the coronal image. Iatrogenic complications. If careful preoperative CT is not evaluated, we all can have or land into problems. They are rare, especially the serious complications such as orbital complications and CSF complications, less than 1 in 200 chance. Even those can be prevented by being prepared. These are few cases which can cause problems if preoperative assessment was not given attention. This is a revision fast polypectomy patient that is dehiscent lamina papyraceae in this coronal image with extensive nasal polyposis. These are axial images with dehiscence. These are sagittal images. Careful attention should be given when removing the polyps near the left eye to prevent any damage to the orbital structures. The same patient had macroadenoma and erosion of the floor of the sella. So sphenoid surgery need to be done with much careful attention to prevent any damage to intracranial structures. Another patient with extensive polyposis and cystic fibrosis had multiple surgeries in the past elsewhere, and his CT scan confirms breach in the lamina papyraceae and also posterior table of the frontal sinus. If attention is not given, these could cause problems. There is another patient, 15-year-old girl with extensive nasal polyposis, and you can see anterior ethmoid artery is much low-lying than the one which we saw earlier image, which was almost flush to the skull base, but this is much low-lying with mesentery. connecting the orbit to the lateral lamella of cribriform plate. This patient is at risk of orbital hematoma, that is by injury to anterior ethmoid artery, if careful attention is not given. Thankfully, the procedure went uneventful. She remained asymptomatic. So this aid murmur always help to assess the CT scan prior to any nasal surgery, so that attention can be given to all the details. Ear emergencies. These are some of the common emergencies that I have come across in my experience at Aberdeen Hospital. A few more cases on ear emergencies. The first patient, a 17-year-old fellow from mountain bike, presented to A&E with after a brief period of loss of consciousness. Clinically, no neurological deficit was noted. He had mild conductive hearing loss and there was blood clot of the ear canal. He was sent for CT head and temporal bone. These are axial images of the temporal bones and the coronal images. In the coronal image, you could see some air pockets suggestive of pneumocephalus. And in the axial image, there is a fracture line running along the temporal bone and also onto the middle ear and dislocating the inguinal joint that could suggest his hearing loss symptoms. He was given an outpatient appointment for further assessment of hearing with ENT, and A&E had discharged him the following day. However, he presented to ENT with grade 3 facial nerve palsy within a week of that temporal bone trauma. This was deemed as delayed facial nerve palsy, managed conservatively with high-dose steroids, and facial palsy completely resolved in 3 weeks. Similar patient had a right temporal bone fracture after a fall. He had a CT temporal bone. These are coronal images, these are axial images. You could see the fracture line running along the roof of the ear canal, and it's a comminuted fracture with some opacification in the mastoid cells and antrum. Another case with transverse fracture of temporal bone, which can cause injury to the otic capsule, that can cause sensorineural hearing loss. It is less common, but can be seen on occasions. Next case, skull-base osteomyelitis. 87-year-old patient presented to ENT with significant ear pain and multiple cranial nerve palsies, grade 4 cranial nerve palsy, and swallowing difficulty. He went on to have CT head, which showed necrotic focus in the petrous apex area. These are axial images. This is taken at the level of clivus, and this one is at the level of occipital condyle. In this image, you could see clear or smooth margins of the clivus on the left side, whereas irregular margins on the right side, suggestive of erosion. And similar thing on the right side, occipital condyle erosion is suspected. This is all suggestive of skull-base osteomyelitis. This patient was treated with long-term IV antibiotics. The patient recovered slowly. Another patient, 85-year-old gentleman, presented to geriatric ward with deterioration in cognition function. He had previous history of malignant melanoma, therefore brain mets were suspected, and CT head was organized by them, which did show flexion in the nasopharynx with necrotic focus and also irregular margins of the clivus suggestive of a lytic lesion. This is the axial image, which shows lytic focus in both petrous apex areas and erosion of the occipital condyle, all suggestive of aggressive pathology, which was discussed in head and neck MDT and skull-base MDT. Patient was unfit for general anesthetic and also for any course of curative management. This was discussed with the family, and a decision was made to go for palliative care. He was given empirical IV antibiotic treatment. Patient, 1-year-old girl, presented with a 5-day history of pyrexia, generally irritable, and it was worsening mastoid swelling. She was given 24 hours of IV antibiotics, but there were no signs of improvement. CT head with contrast was carried out. This is the axial image. The CT scan does confirm, as suspected, opacification of the mastoid cells and bony defect in the lateral wall of the mastoid area with rim-enhancing lesion in the mastoid bone, suggestive of subperiosteal abscess complication from acute otitis media. Child was in the theater. There was already mastoid bone was eroded, therefore the pus drained and smoothened those edges. Grommet was inserted. She was given IV antibiotics for a couple of days, and drain was removed and she recovered completely. Discharged. She remained asymptomatic since then. To conclude, CT is the imaging of choice in nasal or ear emergencies. MRI can act as an adjunct, especially intracranial complications of venous thrombosis. Imaging helps us for surgical planning and diagnosis, confirming the diagnosis, and also to assess the extent. Thank you. Any questions?
Thank you very much, Om Shri. Can you able to see the questions in Q&A?
Yeah, I think there's one question which says, how would you manage a patient with temporal bone fracture causing sensory neural hearing loss in the acute setting? Good question. If somebody has sensory neural hearing loss with a temporal bone fracture, it's more or less a permanent damage, especially if the fracture line is running through the otic capsule. So this patient was sent for an audiology and mainly for assessing the severity of the sensory neural hearing loss, and hearing aid will be the choice depending on the patient's wishes. There is some school of thought to give steroid medications in acute injury, but if there is a fracture line going through the otic capsule, it may or may not be likely that it can improve. Any more questions, I think?
There's one more. Can CS thrombosis be unilateral with the unilateral eye symptoms?
It can happen, and especially in this patient scenario where we discussed, we thought this could be a complication of sphenoid sinusitis, and therefore cavernous sinus thrombosis could have occurred, but it is we couldn't establish a direct cause for cavernous sinus thrombosis, and there is no definitive diagnostic test as well for cavernous sinus thrombosis. It's more of a clinical suspicion and also some radiological evidence. And based on that, we have treated her with long-term anticoagulation and antibiotics.
Brilliant. That's fantastic. I think we are coming to the lunch and sponsor time. I'm going to play 2 videos, one from Stryker and one from PEP test.
Good afternoon. I'm Professor Peter Detmar, and I'm going to give you a short presentation on the role of PEP tests in the management of LPR symptoms. The presentation itself is really split into 3 sections. The first is just to introduce you to pepsin itself. The second part covers some of the work we've done developing and introducing PEP tests as a reflux diagnostic. And the last section covers a validation clinical study which we completed in LPR patients quite recently. On this first slide, obviously the message is that we all know that reflux disease is very common. Up to 20 to 40% of the global population will report with symptoms of reflux. Some of the messages I want to get across here are that unlike acid and bile acid, pepsin is actually present, always present in gastric refluxate. And obviously that gastric refluxate which then gets reflux. So it always will have pepsin present in it. Another clear message is that we use saliva as a very easy to use method for measuring pepsin in clinical samples. And really the last message from this slide is really that pepsin is considered by us and by many others to be a very specific biomarker for reflux disease. And there's many studies have been done in GERD and LPR and respiratory diseases associated with reflux to demonstrate that fact. Pepsin was first discovered back in 1836 and in fact was the first enzyme to be discovered and the second enzyme to be crystallized. So it's got quite a long history. And in the early literature, pepsin was reported to break down proteins in the stomach, which, as we know, that is actually factual. So even back nearly 200 years, that's what it was known to be able to do. Pepsin itself is a major component of gastric refluxate and is one of a family of isoenzymes. So there's from pepsin 1 to pepsin 2, 3, 4, 5. And the pepsin-3 complex, which in fact is the one which we use in our own PEP test studies, is 80% of the total isoenzymes. Main activity at acidic pHs between 2 and 4, active up to pH 6.5 and not denatured until it really gets above pH 7. It's identified in a lot of gastrointestinal conditions, which I've listed on this slide, right the way through from GERD to otitis media with effusion, and is very common in LPR and respiratory diseases such as chronic cough, asthma, and COPD. Detected in saliva, as mentioned earlier, but also I've listed here other media which you can actually detect pepsin in. These are commonly used in clinical trials in particular. Now, as an introduction to PEP test has really been available now for 10 years in the UK and is a marker of prior reflux. It's a very rapid detection system. We can detect pepsin in a clinical sample within 20 minutes. It's been well validated in GERD, extraesophageal reflux and laryngopharyngeal reflux disease. It's commercially available now worldwide, and it's based on a lateral flow test format, And obviously lateral flow tests are very much in the news these days. And the lateral flow format contains two very unique anti-human pepsin monoclonal antibodies. In the UK, it's this is the sort of pack you'll actually see your test in. It's usually 3 samples, sometimes 2 sample collection kits, which are the collection tubes are used to collect the saliva samples in, and it's distributed by BioHit UK throughout the UK. The samples are returned to a central laboratory, RD Biomed, for pepsin analysis, and test results are sent out within 24 at the maximum 48 hours after receiving the samples. So how does it work? There's 2 monoclonal antibodies, as I previously said. One is used to actually detect the pepsin in the clinical sample, which is then using a migration fluid transferred to the test line of the lateral flow device, where there's a second antibody called the capture monoclonal antibody. So it's detected by one and captured by a second, very, very specific human pepsin antibody. And if there's pepsin present in the sample, the T line will light up. There's also a control line which lights up automatically as long as the test has worked. So the readers are calibrated and contain a pepsin standard curve, so that we can detect the pepsin in nanograms per mil within the clinical sample. Now, how do we use the data? The data is used, and I've tried to predict that on this slide really. So if you've got a very, very low level and the detection, the detection is down to 16 nanograms per mil, which is a really minimal level or a physiological level of pepsin, and certainly does not indicate you have reflux disease. We then, if it's 75 nanograms per mil, and then we classify that as a low level of pepsin detection, where we would advise some lifestyle changes and retest again in 6 to 12 months. We can also detect moderate levels and high levels as indicated on this chart here. Now, obviously, the moderate and the high levels of pepsin detection really do strongly indicate that the patient does have pepsin present and therefore reflux present in their sample. I've got a few slides or a couple of slides on the validation study, which was done in the UK in five voice centres in over 1,000 LPR patients. So all these patients were referred from the ENT Clinical Voice Centre with suspected LPR. All patients obviously had a structured history taken and a clinical examination. And all the patients and the control group provided 3 saliva samples for this test. And then the presence of PEP test was tested using the PEP test device. Now, it's not time to go in detail in the clinical samples. There is a publication which has been published around about 6 months ago now, which gives all the detail of the results generated from this study. This is a summary slide showing the 5 centres, which were Doncaster, London, Nottingham, York and Bristol, and the concentration of pepsin present in each of those study centres. The mean pepsin concentration found was roughly 131 nanograms per mil. That's taken across all the 5 centres. Now, if the medication which patients have been put on or lifestyle changes and dietary changes are completely ineffective, there are in fact some surgical procedures which could be used on LPR patients and have been used on LPR patients. The first being fundoplication, which is considered a very invasive procedure, but one which is used, which is quite used, surgically routinely used. One of the issues with this is that some patients will have breakthrough symptoms after 12 to 24 months. And in fact, pep test has been used to measure pepsin levels with patients who do have symptoms after a 12 to 24 month period. There is an endoscopic procedure, the stressor procedure, which is only minimally invasive, and that's being used more and more now on LPR patients. They claim reasonably good symptom improvement, but there's far more evidence is required to actually be able to substantiate that. And the last procedure I've just listed on this slide is the linked surgical procedure, which again has been used with some success in LPR patients. In conclusion, pepsin is now recognized as a biomarker of reflux disease. There's hundreds of publications now presented across the world literature indicating that fact. And pepsin and pep test is now widely available in a wide number of clinical papers. Pep test itself is available as a first line and very rapid non-invasive reflux diagnostic test. Pep test has been validated in GERD, extraesophageal reflux and laryngopharyngeal reflux studies. Pep test is available not only in the clinical situation in hospitals, but also in primary care. And it's now being commercialized and is available now in fact, I got 49, it's well over 50 countries now. Two of the leading countries using pep tests are in fact the USA and China. Thank you for listening. I'm sorry for such a brief talk, and I hope the brief introduction for you for both pepsin and for pep test will actually lead you to ask maybe further questions, and those questions can be put through the Biohit company, and we will make sure that those questions are answered for you. Thank you for listening.
Hello all, my name is Trishna Lakhani. I'm the Territory Account Manager for Stryker ENT North. Stryker is one of the world's leading medical technology companies, and together with our customers, we are driven to make healthcare better. Today, I would like to introduce you to Stryker ENT navigation system, Scopus. Scopus software offers standard of care electromagnetic technology combined with innovative target-guided surgery and augmented reality. TGS technology introduces augmented reality to FES procedures and merges the pre-operative plan with the endoscopic image to offer real-time anatomical guidance directly on the surgical monitor. A special instrument guidance and notification system helps guide your endoscopic instruments on pathways directly to the targets. We will be holding a live 30-minute Q&A and demo with one of our most experienced users from Canada on Tuesday, 11th of May. To register, please contact me on 07970 625 979. That's 07970 625 979. I will now leave you with a short video of this great system in action. Thank you.
that's brilliant. Thank you. It's a lunch break. We'll be back at 1:30, so which means 43 minutes, 45 minutes break. So we'll be back at UK time 1:30, 45 minutes break. Thank you.